Okay, thank you so much for that. I always find it fascinating to see the sort of journey we've been through in different healthcare systems to end up where we are today. We're going to make another journey now from Australia to Europe. And just in case the first time I said it wasn't cliche enough, our next speaker's also literally written the book on her topic. So Sarah Thomson is a senior specialist with the World Health Organization Regional Office for Europe and is based at the WHO Barcelona Office for Health Systems Strengthening. She's also an associate professor at the London School of Economics and Political Science and a senior research associate at the European Observatory on Health Systems and Policies. Her research focuses on health systems, healthcare reform, and health financing policy in high-income countries. And today she's going to talk about how governments balance public and private financing in Europe. And that talk's called Hard Work for Government, Balancing Public and Private Financing in Europe. So welcome. Thank you.
Thank you, Mark. Thank you, Mark, for the introduction. Thank you very much for inviting me to be here to speak today. It's my first time in Vancouver. In fact, like Anne-Marie, it's my first time ever in Canada. But I've worked with many Canadian researchers in the past. And in fact, my first interest in looking at this very challenging and interesting mix between public and private financing in health systems was really largely triggered by reading the work of Professor Bob Evans when I was a postgraduate student in London. So I'm really happy. My first visit to Canada should be to take part in a gathering that's organized by the Centre for Health Services and Policy Research. I'm going to look at how health systems in Europe try to balance public and private spending, and I'm going to look at the lens of universal health coverage, which is really this idea that everybody should be able to use the quality health services that they need without incurring financial hardship. And from what I've heard this morning, this is very much in line with the Medicare Protection Act and the principles of the Canada Healthcare Act as well. The European experience, and actually the global experience, makes it really very clear that in order to achieve this set of policy goals, health systems need to rely very heavily on public spending on health. But it also shows that coverage policy needs to be really carefully designed to ensure that nobody experiences unmet need for healthcare and that nobody experiences financial hardship when they're able to use health services. But if there are gaps in publicly financed coverage, it may be that there will be a role for private health insurance of some sort on the grounds that some form of prepayment with risk pooling is preferable to people simply paying out of their pockets for healthcare at the point of use. So I've divided my talk into 4 parts. First, I'm going to identify the gaps in publicly financed health coverage in European health systems. Second, I'll look at how well private health insurance does in filling these gaps. Third, I'm going to illustrate why this is often really hard work for government. And then finally, I'll conclude with some lessons from Europe. I don't know if these will be relevant to Canada or not, but lessons from Europe. First, where are the gaps in coverage in European health systems? This slide shows you how countries in Europe finance their health systems. It's a breakdown of total spending on healthcare, and you can see it's the 3 main mechanisms that countries use to finance healthcare. In all of the spending on health dominates, that's the green at the top of the chart. Private health insurance plays a role in most countries, and that's the yellow at the bottom of the slide. But in most countries, its contribution to total spending on health is really, really small. And the big chunk in the middle, between the green, the public spending, and the private health insurance, is where the gaps in publicly financed coverage really are. This is the out-of-pocket payments. And you can see that all countries in Europe rely to some extent on out-of-pocket payments to pay for healthcare. So there are gaps in coverage in all countries. This slide shows you how different healthcare are financed using these 3 mechanisms, and it gives us a slightly better idea of where the gaps in coverage are across countries. You can see that for inpatient care, ancillary services, outpatient care, the green is really dominant, but when you move across the chart to medical products, to outpatient medicine, dental care, you can see that the public spending share is much lower, and this is where the really large gap, the largest gaps in coverage are. A question for policy: do these gaps in coverage actually matter? Could it be the case that it's really rich people choosing to spend these things, and so out-of-pocket payments don't really create a barrier to access, and actually they don't really create financial hardship for people either? Well, the analysis that we've done shows that this is emphatically not the case in European countries. In this, we see the share of households across a lot of countries in the EU with catastrophic spending on health. This is a very common measure of financial hardship. And here it's broken down by quintile, by income quintile. And the darkest bit of each column is the poorest fifth of the population, and the lightest bit of the column is the richest fifth of the population. And what you see from this is that, yes, there is financial hardship in all of these countries, but it's consistently heavily concentrated among the poorest fifth of the population. Because we're short of time and Mike asked us to keep to our time limit, I'm not going to show you evidence on unmet need for healthcare, but take it from me, and in the slides that are circulated at the end, I'll make sure that everything is there. But gaps in coverage also lead to unmet need for healthcare in European health systems, for healthcare, for dental care, for prescription medicines. And again, unmet need for healthcare is consistent in the poorest fifth of the population. One last thing to say is that the poorest households in European health systems are mainly spending on outpatient medicines, much less on dental care, because most people experience unmet need for dental care. The numbers that I've shown you don't really tell us much about the policies that lead to gaps in coverage. So to do that, we can look at the three dimensions of coverage policy illustrated by this cube. First of all, people may lack coverage at all. In EU health systems, popular coverage is generally very close to universal, but there are significant gaps in some instances. For example, for undocumented migrants who never benefit from the same degree of coverage as the rest of the population. There are also gaps in countries that link entitlement to publicly financed healthcare to the payment of contributions. These are called social health insurance contributions, and this happens in around half of all EU countries. In the past, this was mainly an issue in countries with large informal sectors, but as labor markets have become more precarious in Europe, it's going to become a much bigger issue in future. And in WHO, we are being increasingly vocal about this. Linking entitlement to publicly financed healthcare, to payment of contributions, is just not consistent with the goals of universal health coverage. And right now, in the 21st century, there is absolutely no reason why any type of health insurance, health coverage, should be based around employment. This is an idea that had its roots in the Middle Ages and really took hold in the 19th century, but this is not something that is fit for purpose in today's world. Having said that, it turns out that lack of coverage isn't really the main driver of financial hardship for households in EU health systems. And this is largely because people who lack coverage, who are not covered, experience unmet need for healthcare, so they don't even get to use services and get to pay out of pocket for them. The scope of the benefits package, the publicly financed benefits package, is pretty comprehensive in most countries. The biggest gap is dental care, and dental care for adults who never have, usually don't have as good coverage for dental care as children do. But here we see that there are different responses between people in the population. So poorer people are much likely to experience unmet need for dental care. If there is financial hardship associated with the use of dental care, it tends to be among richer households, people who are actually able to afford to pay the user charges in the first place. Even though benefits packages are often comprehensive, people in health systems may face waiting times for treatment, something that you're familiar with here in Canada, I know. And again, the effect is that unmet need is something that the poorer households will experience, but financial hardship incurred by those who are actually able to afford to pay anything at all. But the most consistent gap in coverage across countries comes from user charges, from co-payments. There's a lot of variation application of user charges in EU health systems. Many countries don't make people pay for primary care on the grounds that it's an essential form of service, but bizarrely, all EU health systems charge people for outpatient prescriptions, even though outpatient prescriptions are an essential part in primary care. But this is a commonality across countries. There are 3 honourable exceptions to this in Scotland, Northern Ireland, and Wales, but every other country makes people pay for medicines that a doctor has prescribed to them. So, identifying gaps in coverage, I think, provides a really clear signal for policy. In Europe, efforts to reduce unmet need and financial hardship really need to focus on reducing user charges for outpatient medicines and improving the coverage of dental care, particularly for adults. And they really need to focus their efforts. They need to by focusing on improving coverage for poorer households. I think the question here is whether private health insurance can be the Heineken of the health policy world. Is it a policy instrument that can reach out and refresh those parts that other policy instruments cannot reach? And the short answer is not very well. Private health insurance plays different roles in different countries, and we can measure the size of the markets across these countries in 2 ways. We can look at the share of the population that's covered by private health insurance, which is the yellow bit of the column, or we can look at the share of total spending on health that comes through private health insurance, which is the dots at the bottom. And as you've seen already, that's very, very low in most countries. There are only 3 countries in which it's more than 10%, France, Slovenia, and Ireland. In terms of the share of the population covered, again, there's variation. So if we look at private health insurance markets that cover services that are excluded, these are really very small. The only exception, there's a large market in the Netherlands, but the Netherlands is an unusual example. If we look at private health insurance covering user charges, more markets like this, but most of them quite small, and then 3 exceptions, Croatia, Slovenia, France, where actually they've managed to achieve quite a high level of population take-up. And then the last role for private health insurance is what you guys call duplicate insurance. Here, this is where private health insurance, like in Australia, offers people faster access, basically, to treatment in hospitals, particularly where there are long waiting times for this. And you can see that in most of the countries here, take-up of this type of private health insurance is really, really small. Not because there are no gaps in coverage. Out-of-pocket payments in these countries are really high, but because markets just don't develop to cover them, or because people can't afford to pay for them. And if we look at what private health insurance is buying, is spending on, it's really focused on inpatient care and outpatient care. There is very little private health insurance spending on services that are creating gaps in coverage, so the outpatient medicines and the dental care. Okay, the third part of my talk. Why is private health insurance such hard work for government? Well, if any of you have read Anna Karenina, and if you haven't, you should, you will know that it had a really great opening line in which the narrator observes that all happy families are basically the same, but each unhappy family is unhappy in its own way. And I think this is really true of private health insurance. The pain that private health insurance can bring for government is really highly context-specific. Having said that, I think it is possible to identify some common challenges, and I'm just going to go over some of the common challenges very quickly and then illustrate the more complex challenges through 2 country case studies. I want to look at France and Ireland. So common challenges first. The first one is inequality, and we've heard a lot about that already this morning. One of the reasons for this is that insurers in voluntary markets are often very risk-averse, and this survey that we did of private health insurance markets in 34 countries shows you that in most of these countries, insurers adopt strategies to minimize their own exposure to risk. So they have risk-rated premiums, they don't cover pre-existing conditions, they don't offer open enrollment, so they can reject people if they don't like the look of them, and so on and so forth. And this means that private health insurance is not always accessible, certainly not affordable for people. And because of this, we see across countries that private health insurance systematically favors richer people, people living in cities, more educated people. So it is very clear that if you promote private health insurance, you will increase the inequalities in access to healthcare and affordable access to healthcare in your system. The second challenge is spillover effects. Negative spillover effects, which are really likely to occur when the boundaries between public and private provision of healthcare are either not clear, or if they are clear and they're not well enforced. And we heard a lot about the lack of enforcement earlier today. Spillover effects also take place where there are incentives for providers to prioritize patients who are financed through private health insurance. There are also spillover effects where governments use private health insurance using tax dollars, and these tax dollars are used indiscriminately. They're not used to target poorer households, they're just given to people who want to buy private health insurance. And these factors mean that private health insurance can really skew resources away from publicly financed need. And then the third challenge is complexity. Private health insurance markets really add to a health system's complexity, and we know that this increases transaction costs. It's challenging not just for the policymakers who have to deal with it, but I think particularly for the people using it. Coverage policy is one area where complexity really sucks. People need to have very simple entitlements to be able to understand what those entitlements are. And the combination of these three challenges can mean that private health insurance, particularly if it's large, publicly financed coverage. I just want to illustrate this with two country examples. First, France. So France has a market covering user charges. The French have very high user charges for all health services in the form of co-insurance, private health insurance if you want to avoid financial risk in out-of-pocket payments. When the French government established its national health insurance system, it had a problem on its hands. It had to decide what to do with all the mutual associations that had been providing voluntary health until that point, a legacy problem like the one that Anne-Marie talked about in Australia. The government decided not to give national health insurance to those non-profit organizations, but to create new institutions, but it felt it had to compensate those mutual associations in some way, and so it created this role for voluntary health insurance. The government also thought that it would be very smart and it would impose user charges, so it would maintain some fiscal relief for itself. It would shift costs onto households, but allow these households to buy voluntary health insurance to get protection if they wanted to. At first, the co-payments were very low and the demand for private health insurance was very low. But over time, the government continued to push more and more of the costs onto households, and the demand for private health insurance went up, until by 2000, it was covering 85% of the population, a really high share of the population. Now, you might think that if private health is covering co-payments, it's a really good thing that 85% of the population has that protection. But what about the 15% who don't have it? Who are these people? And by the late 1990s, the French government became really concerned about this because there was solid health services research evidence that showed that the 15% were not just young people who didn't need private health insurance, who weren't at risk of going to the doctor. It was really very disadvantaged people. So the government was very busy then for the next few years, introducing a range of steps to make private health insurance accessible and affordable, particularly for poor people. The big came in 2000 when it made private health insurance free for very, very poor households, and it did this through taxing the insurance industry. But this wasn't enough. So in 2005, it introduced some subsidies for people who were not very, very poor, but quite poor. This wasn't enough either. At the same time, commercial insurance companies had been entering the market, and their practices were a little bit different at this time from the mutual associations that had been there originally. So the government then introduced a whole range of different types of tax, carrots and sticks, to try and direct insurers to behave in a particular way. And this ended up with a of legal challenges, something that you are very familiar with here. it wasn't enough. So by 2016, the government then decided that employers should have to buy or should have to offer private health insurance to their employees, and they should also have to pay for part of the private health insurance for their employees. It's really a lot of work on the part of the government. What's the outcome? You can see here that among the poorest fifth of the population, there is still a substantial part of them who don't have private health insurance. Some of them now benefit from free or subsidized health insurance, but they still don't have, many of them don't have private insurance. Because of financial barriers, the subsidies are not enough, they still can't afford to pay it, but also because of administrative barriers. Somehow it's not easy to benefit from the free private health insurance or for the subsidies. You have to apply, it's a company, and this is an obstacle for some people. So the upshot that is 4 million people still uninsured, most of them poor. So a huge amount of work on the part of government, heavy regulation, subsidies for poor people. Yes, it has take-up of private health insurance, and yes, it has reduced out-of-pocket payments for households, but inequalities still persist in the health system. There are inequalities in access and use of health services. It's inequitable in terms of financing the health system. Private health insurance premiums are highly regressive. They pay a much higher share of their income for these premiums than the rich do. And if we look at catastrophic health spending among the poorest fifth of the population, you can see that there are clear differences between people who have private health insurance, people who don't have private health insurance, and people who have this subsidized or free private health insurance. So size matters. When you have private health insurance covering user charges, it really needs to be affordable for everybody who needs protection from user charges. But I think the clear lesson from France is that it's very hard to reach poor people using this particular instrument. Ireland has a really different type of private health insurance market. It has a market that's much more like the market in Australia that Anne-Marie talked about. Again, a very similar legacy issue to Australia. In 1957, the government was not covering richer people for hospital care because it wanted to save money. It was thinking about fiscal relief. But in order to compensate these people a little bit, it set up a non-profit insurance company that would offer voluntary private health insurance to these people. And because the government wasn't paying for the hospital care for these people, it felt that it was reasonable to give them tax subsidies to encourage them to take up private health insurance. At the same time, it felt it was reasonable to allow these privately financed patients to use private beds in public hospitals. It allowed the doctors treating those patients to charge higher fees to the people with private health insurance. So there were very clear incentives, as Jerry Hurley talked about earlier, for doctors to give priority to people with private health insurance. By 1991, richer people were actually entitled to inpatient care. So the only difference between richer people and the rest of the population at this point was that they had to pay user charges for hospital services. But because of all the tax relief to promote private health insurance, because of all the perverse incentives in the system, the lack of clear boundaries, and so on, the demand for hospital treatment grew, the waiting times increased. As waiting time increased, many non-rich people started to buy private health insurance, and the waiting times increased even more. 2002, the government decides it's got a real problem on its hands and it needs to start buying treatment for public patients in private hospitals. There just isn't enough capacity in public hospitals. A whole range of other steps taken. Finally, in 2014, the government puts a levy on the use of private beds in public hospitals, but the weird way in which this levy works and the fact that you still get paid less for public patients in public hospitals and more for private patients in public hospitals means that hospitals actually want to keep up their private bed capacity to the maximum. And then in 2015, the government, on top of all this craziness, decides that it's going to penalize young people if they don't take out private health insurance, and then is using public hospital treatment grows. And that, I think this is the definition of a truly vicious circle. Oh, and don't forget legal challenges. Commercial insurers enter the market, challenge some of the regulations, and the story goes on. So Ireland, indiscriminate tax subsidies, perverse incentives in this, blurred boundaries between public and private practice, skew resources away from need. You have the poorest people paying taxes that subsidize private health insurance for richer people, half of private health insurance finance care taking place in public hospitals, with a huge increase in waiting times, not just in waiting times, but in the waits themselves. And people, half of the population saying, I buy private health insurance so that I can jump queues. And private health insurance is a necessity for me. It's not a luxury, I need this. So once again, size matters. When it comes to private health insurance of this type, duplicate private health insurance, small is beautiful, or at least less ugly than large, and very, very, very small. And the reason the size is important is because once the market becomes larger, the interests become really difficult to manage. It's not just the private insurance companies, it's the physicians and the hospitals that benefit from the perverse incentives in the system, and it's the rich people who have private insurance who stand to lose if that is taken away from them. And this triumvirate of interests is very, very powerful indeed. So let me conclude with some lessons from Europe. Countries in Europe have often encouraged private health insurance because they see it as a way of generating fiscal relief for the government. But as we've seen from the European experience, private health insurance is also really hard work for government. It comes with costs. However, many of the challenges that private health insurance brings are really predictable. It is a predictably challenging policy instrument. Economic theory tells us how insurance is going to behave in a voluntary market. We know that there are going to be problems with access and affordability for some people. We know a lot about the international experience now, and this very clearly shows us that one of the failures of private health insurance to perform in the way that governments expect it to is because of weak public policy. The poor design that Anne-Marie talked about, the failure to clarify boundaries, the failure to manage interests. But context is really important too. In the time when most European health insurance markets were established, they were dominated by mutual non-profit associations that played a very specific social function. Then the markets changed. Those days are long gone. Commercial insurers entered the market. In the European Union, we now have a single market in insurance, and that has been the cause of some of the legal challenges that I mentioned. It's often very hard to tell the difference between the behavior of non-profit and for-profit entities in a competitive health insurance market. So in Canada, you already have a large private health insurance market, a mature private health insurance market, and you're also living next door to the mother of all health markets. And I think the implication of this is that it is likely to make the interests even harder to manage. So my question for you is it worth it? My final lesson from Europe. Some of you may have seen an American film in which a White House spin doctor and a Hollywood producer fabricate a war in order to draw attention away from a presidential sex scandal. And this reminded me of private health insurance, the European experience, because in many countries, the tail has ended up wagging the dog. Countries, policymakers are spending so much time and energy trying to fix the private health insurance market. This is really not something that you want to be doing in Canada. Don't let the tail wag the dog. You do, unlike watching this film, which is supposed to be swift and hilarious, you'll find that it's really slow and tedious. It's much better, if you can, to focus the time and energy and the resources that you have to improving the publicly financed bit of the system, to focus on redesigning coverage policy, to close the gaps that you know that you have that lead to unmet need and financial hardship, so that people don't actually need private health insurance in the first place. I think this is where governments should be doing the hard work. And I think the European experience shows us that private health insurance is definitely not going to do this work for government. Thank you.
Okay, so thanks very much. That was another great talk. So we're into the session, part of the session now where we can ask questions. Just before we dig into these, can I just remind you to please get engaged and use the upvote facility.